Great. So Howie, two things. First of all, you have an incredibly rich database from which you've crafted a superb presentation. For CoreValve, there's also an incredibly rich database which is locked and not accessible to anyone alive as of yet. But we'll get there.
Thank you for your talk, Neal.
So number two, Howie, as I've learned, if next time I'm in Tokyo and I've got to go somewhere, I'm going to walk. So I was asked to give an update on CoreValve, and I thought I would start with a nod to our absent moderator, Dr. Grube. This is the first case report of a CoreValve implantation. And, you know, this is 2006. You can take away a few things. First of all, the design of the valve is somewhat different with a much larger high radial force portion and a longer skirt. You know, there are some advantages to longer skirts, I guess. And I've highlighted some of the description of the implant. This was a 25 French sheath. This was done in a patient under general anesthesia on cardiopulmonary bypass. And in fact, the device was advanced with the help of a snare inserted from a different axis to help guide it and center it in the ascending aorta. Obviously, as I think everyone here knows, we've advanced since that time. This slide shows you not the current iteration, but the next set of iterations of the valve, the Evolute valve, which will be cut from a different block of nitinol, slightly shorter than the current iteration, as well as a variety of delivery systems that are somewhat easier for the second operator to use in planting the valve. So tremendous iterations have been developed and are in development in the relatively few years since the first implant. So where are we now? Well, first of all, Howie has shown you some great data from two randomized clinical trials. There are two randomized trials of the CoreValve device modeled after partner trials, Extreme Risk, which was called in the partner world inoperable, and then the high-risk group. These trials are somewhat larger than the partner trials, but like the partner trials, they are based on a surgical assessment of the patient's operative risk, guided by STS scores. And as part of the screening procedure for these trials, we have added a few experimental modifiers to the STS score. The database will allow us to evaluate the value of those modifiers, such as being wheelchair-bound, home-bound, oxygen-dependent. Those aren't in the current STS score. We'll be evaluating, we'll be able to learn a